Let us skip this slide and let's come to the side effects. So this really explains it as to why we are a little equivocal about recommending this combination for everybody. Because if you see on the left hand side, osimertinib plus chemotherapy, almost all side effects were more common. And that is very common because whenever you're giving two different toxic compounds to a patient, this drug A's side effects will be there, drug B's side effects will be there, and both will combine to create even more side effects. So if you look, and when you give chemotherapy, because these drugs, of the way they work on the bone marrow, the hematological side effects, drop in your hemoglobin, WBC count, platelet count, all these things are very common. So you can see that all hematological toxicities like anemia, your neutropenia, thrombocytopenia, which were very uncommon with osimertinib, they were far more common with this combination. Even quality of life impacting parameters like fatigue, skin rash, oral ulcers, and diarrhea, that is your GI toxicities, were also more common with this combination. So of course there is you cannot they say you cannot have your cake and eat it too. So with any combination you have to be very mindful that it comes at its own costs. Nothing is without additional side effects. So you have to be very careful of the patient population in which you are recommending this combination. For example, if an 80-year-old lady comes to me in a wheelchair with the diagnosis of EGFR-mutant lung cancer, I am not going to be advising her a combination of osimertinib plus chemo, because after the first cycle, she will never come back for the next cycle because of the side effects. On the other hand, if it's a fit 55, 60-year-old gentleman with no other health issues, who is absolutely fit and fine, we'll not have any qualms about recommending this combination, because he has a long way to go and we need to give him the best treatment possible. So this slide again tells you about the side effect profile. It was very similar across all the landmark studies. The previous studies which I told you in the previous slide, the Japanese trial, the the TMH study from Bombay, and the FLORA2 trial, again across all the trials, the incidence of major toxicities was much more common in the combination arm as expected. So again, this slide again tells you about the differences between the FLORA and the FLORA2 trial. So the FLORA trial was the trial which established osimertinib in the first line setting, and the efficacy of the significant improvement in PFS you can see here. That is, it was 18.9 months versus 10.2 months. And FLORA2 has established the new standard of care, that is 25.5 months, which was previously unheard of in this kind of patient population. And this has impacted our practice, like I was saying. So let us again skip this. Let's finally look at, this is my penultimate slide. So this is where we are heading into the future, because now we are with the advent of next generation sequencing technology, we are able to pick up circulating tumor DNA from the patient's bloodstream by using highly sensitive molecular diagnostic tools. We can pick up even nanograms of cancer DNA which are floating in the patient's bloodstream, and we can analyze that cancer DNA and with equal accuracy as a tissue biopsy. So in fact, even today in our clinic, patients who are unwilling for a tissue biopsy, like say you have a lung mass and the doctor advises a tissue biopsy to know what kind of cancer it is. And say if the tissue biopsy is not of a good quality, or say if in the initial tests the entire material is exhausted. So even as of today, a liquid biopsy has been shown to be as sensitive and as precise as a tissue biopsy in picking up whether these patients have those mutations like I mentioned or not, including the EGFR mutation. So this is where we are going into the future. This is an ongoing trial known as the EGFR Shedders trial. What it is doing is it is initiating patients on osimertinib. After 3 weeks of therapy, it is then randomizing patients into two arms. Those who have persistent ctDNA detected in the bloodstream, these are the high-risk patients. They are then randomizing them to either continuing only osimertinib or then adding some additional therapy on top of that. And basically with this we will know whether patients who are at higher risk of relapse, whether they benefit with this individualized approach or not. So to conclude, osimertinib in combination with chemotherapy has demonstrated a significant and a clinically meaningful improvement in progression-free survival compared to monotherapy. It has a good hazard ratio of 0.62. Both as per investigator and blinded independent central review assessed PFS, it was much superior than monotherapy. And like I said, again, the group of patients who would benefit the most with this combination are the patients who have brain metastasis. And the side effect profile was as expected. When you combine two toxic compounds, the side effects will be much more, which is why you need to be careful about which patient population you advise this combination in.